We welcome you back to the sixth session of this meeting. As we have seen, we've all been impressed with the quality of the presentations and the organization. So we again thank the organizing committee for such a truly pleasure to be in this meeting. We'll welcome again Dr. Ramzi Tabbalat. As we all know, he's a well-known cardiologist in Amman, and we'll start with a very interesting discussion of patient deterioration after EVAR. Welcome back, Dr. Ramzi.
Thank you, Dr. Farid. If we can have everybody please have a seat. Okay, so this patient is a 74-year-old male. In 1993, he was diagnosed with peripheral vascular disease, sustained an acute inferior myocardial infarction for which he received STK, had cath, which showed 75% RCA, 40% right common iliac artery stenosis, and 100% occlusion of the right superficial femoral artery. There was also a tight ostial lift common iliac artery stenosis. I think at that time he was treated medically. In 1997, cath was again done, and it showed the total occlusion of the right coronary artery with collaterals. 2000, he had bilateral aortoiliac wall stents placed in both iliacs, and in 2003, he had occlusion of the stent in the right common iliac artery with minimal stenosis in left stent. 2005, carotid Doppler showed 16% stenosis in the right common carotid artery, 30% stenosis in the left common carotid artery. 2008, he presented with chest pain. Cath showed totally occluded RCA, which he had before, and there was a new 90% mid-LAD lesion. A stent was placed in the LAD, and he was fine. He presented again in January this year, where he had, for some reason, he also had a COPD, so he had a chest CT which showed a dilated descending thoracic aorta. The diameter was 5.5 centimeters. At that time, he was advised follow-up and no intervention. In the 14th of July, 2019, a repeat CT was done, and the aneurysm now was 58 millimeters in size with the presence of mural thrombosis. His ejection fraction on the echo was normal. So his past medical history was significant for hypertension, diabetes, hypercholesterolemia, and he was also a smoker. His medication include metformin, amlodipine, bisoprolol, telmisartan, hydrochlorothiazide, rosuvastatin. An ECG showed normal sinus rhythm with a right bundle branch block. His hemoglobin was 14. He had some reduction in his kidney function with a creatinine of 1.4. The A1C was 6.6%, NT-proBNP was 317, CRP was 9, and his cholesterol was 173, the LDL was 72 on rosuvastatin. So, since the aneurysm was now the proper size for intervention, we decided to go ahead and do an EVAR. We used the Valiant Captiva thoracic stent graft, 40 by 40 by 200 millimeters. The left femoral artery was chosen as an axis because of the totally occluded right common iliac stent. We placed two ProGlide closure devices pre-procedure, and the procedure went without any problems. So this is supposed to be a video here. Anyway, so these are just cinefilms just to show you the completion of the procedure. There were no problems. The procedure was finished, and the patient was feeling fine. He came back 5 weeks post-procedure, complaining of fatigue, nausea, and weight loss. And he reported that these symptoms started right after he had the stent placed. His blood pressure was 90/60. His ECG was normal sinus rhythm. Echo showed normal ejection fraction, no pericardial effusion. Because of his low blood pressure, we decided to discontinue his antihypertensive medication. His hemoglobin was 12, less than what he had prior to the operation. His white count was a bit elevated, 11.8. His ESR was 118, and the C-reactive protein, which was normal prior to the procedure, was now 76, highly increased. And his kidney functions have deteriorated over the past 5 weeks or so. His liver function tests were normal. So I don't know, do you want to say something about this?
Clearly, very complex patient medical history with significant involvement, but clearly you're dealing with a problem that will raise the question of serious infection that this patient is having, and we all at this point hoping it's not the graft, because that will be some serious issue. And then that's where I would wonder what the panelists would think the next step in management in this situation once you have these numbers.
Probably need to get a CTA of the chest, abdomen, and pelvis.
Can you speak up, Ali Sotak?
Needs to get a CTA probably for this patient to rule out infection, definitely.
Anybody else? Any CTA without contrast because of his kidney function?
Well, I didn't see the,
high resolution.
Okay, see, yeah, you get a CT without contrast. Still, it's suggestive whether you have infection or not. You can get also a nuclear study where you have a basic nuclear uptake study that shows the graft lights up, it's infected basically. So based on this, although the culture is negative, so I don't know if it's infective or not yet. So usually the culture is positive.
I think that's an important point Dr. Rafat is pointing out, that if you could augment the imaging with a white blood cell tagged study, that may actually seriously help you with that.
Or non-contrast CT also.
With the
you see
non-contrast.
sometimes gas, you see air, you see stranding around it, so you don't have to. I get a CTA for those patients to rule out fistula, but the non-contrast study, you see gas, you see air, you see stranding, you see signs of infection on it too.
So I see definitely there is an element of either inflammation or infection.
But
All the parameters of reaction is there, and you have to differentiate whether it is an infection or inflammation. I think this is the basic of what we are at this level.
So, this is exactly what what we thought of. We thought of infection, and we had to rule that out. We did a CT without contrast, specifically looking at the graft and looking to see if there are any bubbles around the stent graft suggestive of the presence of infection. We did 3 sets of blood cultures, aerobic and anaerobic, and they all came back negative. We also did the urine culture that came back negative. Empirically, we started them on oral antibiotics, just I don't know why, but just to cover for
to me, the fact
infections 500 milligrams by 2.
To me, the fact that blood cultures are negative, to me, I really don't think it's graft infection.
Can you raise your voice?
Please
The
speak up,
fact that blood
Dr. Ali
cultures are
Sotak.
negative, it doesn't appear to be a graft infection. Usually, my experience, and I do about 15 a year of those, I've never seen any blood culture that's negative with those.
So anyway, we did that, and he came back. We gave him the antibiotics. He left. He did not have to be admitted. He came back 7 weeks post-procedure, 2 weeks after the first checkup, and he was still feeling tired. He's lost about 10 kilograms now. His blood pressure was high. He had hypertension before, and now we felt that he was too sick, and that still we don't have a diagnosis on this patient, and we felt that he needed to be admitted to the hospital. He was admitted, blood pressure 150/80. His hemoglobin is now even less than before. The white count is even more, 12.9, with 65% neutrophils, 23% lymphocytes, 7% eosinophils. His creatinine, was 2.17, and his ESR now is 120, and the C-reactive protein is still extremely high. So diagnosis, treatment, do you have any suggestions? If you do, please make it short because we don't have time.
Just a question, Dr. Ramzi. Is there a role for transesophageal echo to evaluate that area?
Transesophageal echo, I don't think so. I don't have experience with transesophageal echo in evaluating stent grafts. I don't know if anybody else has any experience, but I doubt that a transesophageal echo will help you in making a diagnosis of infection. A CT scan may be more appropriate in these cases. Anyway,
there is a possibility of atherosclerotic disease, which may also give rise to the same picture.
Atherothrombotic disease. So the present, Okay. But he clinically had no evidence of the presence of thromboembolism, either vascular or extravascular. So there was no issues. So again, we thought of infection, and we thought that there was an infection somewhere that we could not detect, that we needed to treat. And then we became aware of the presence of something that is called the post-implantation syndrome, which I will tell you about. So at this stage, because he continued to be sick, and his ESR continued to be high, his C-reactive protein was high, and he was feeling sick with leukocytosis and also with significant weight loss. This time we started IV antibiotics with meropenem and Targocid. Again, I have to mention that we repeated the blood culture once again, we repeated the urine culture again, and they all came back negative later on. And we thought that because we considered an alternative diagnosis that is not infection, the post-implantation syndrome, we started them on a high-dose methylprednisone. So we came back 5 days later, and he was feeling much better. He was feeling like a new man, feeling dramatically well, normal appetite. He started eating, he started to walk around, he was fine. His hemoglobin is 10, white count still high, but this is now he's on steroids, so that may explain the leukocytosis. His urea has dropped a little bit, his creatinine has improved. ESR is still high, but the C-reactive protein came down from 76 to 26. And now we had him on a oral prednisone, 30 milligrams per day, and he was still receiving the Targocid, which was started 5 days ago. He still had 2 days of Targocid on board. So there was a very significant improvement quickly in 5 days, which usually made us lean more towards the presence of a post-implantation syndrome rather than the presence of an infection. So this is on the 16th of October. The patient was feeling now very good as new. His creatinine is now better, his urea is better, his white count still high. His ESR dropped to 11 from 120, and his C-reactive protein is now normal. And he was on a dose of 20 milligrams of prednisone daily. So substantial reduction in these parameters. So what is post-implantation syndrome? Because I only have 4 minutes. It's the clinical and biochemical expression of an inflammatory response following endovascular repair of an aortic aneurysm. First described in 1999, and it may affect about 1/3 of patients post-EVAR. The range is between 14%, 60%. This is because of all of these studies were small studies and case reports. Signs and symptoms, it's defined when you have a fever of more than 38 or leukocytosis more than 12,000 with an elevated C-reactive protein of more than 10. If you have these things, that you can safely make a diagnosis of you can consider post-implantation syndrome. And it has to be considered always in with evidence of absence of infection through a full workup for infections with cultures and everything else. It's generally, in most of the patients, it's a benign condition, but in some patients it may negatively affect outcome. Theories for what it causes it. There are theories that related to inflammatory response, anaphylactic response, and infectious response, but none of these theories are proven. We don't have to go over these, but they can be related to foreign body, to injury, to vascular wall, endothelial manipulation, nuanced symptoms, contrast media, allergic reactions, elevated levels of cytokines, possibly of bacterial translocation. All of these were theories to explain the nature of the post-implantation syndrome. The treatment is controversial. No specific algorithm of treatment or management is advocated for these patients, but the use of anti-inflammatory drugs can be given in the early phases of the PIS. High-dose steroids can be used prophylactically pre-procedure sometimes to prevent the occurrence of PIS, but it can be also prolonged oral treatment, and sometimes high-dose IV prednisolone can be given to seriously ill patients. Statins can also be used because of their anti-inflammatory properties. Usually these patients will improve without any sequelae, but as you saw in our patients, he really was sick, and we're happy that we made that diagnosis and we treated him the proper way with high-dose steroids. And now he's doing very well. Thank you.
Dr. Ramzi, can I ask about the period after implantation syndrome? When can we expect it?
It usually starts 5 days post-implantation. So that the first 3 to 4 days the patient is fine, and then 5 days and on, the patient will start complaining of these symptoms. So this is how it starts. In our patient, it started, probably in that range, but he did not consider there were significant enough symptoms to come back to the hospital and seek our advice.
It's really important. It's almost never rare infection without positive blood cultures. It's always blood cultures.
How common? It really affects about 1/3 of the patients, but the range is wide, 14% to 61%. This is because there are no randomized trials looking at this. All the reported cases come from very small, single center, single person experience, or from case reports. But it affects 1/3, and that's why a lot of people advocate prophylactic use of anti-inflammatory drugs or even steroids prior to the procedure, even in the first few days of the procedure, to prevent it from
We have the last
occurring.
question, just to keep us.
Ramzi, I know that you have limitations to use therapeutic intervention in this patient with rising creatinine. So if this patient had normal creatinine, would you have jumped to steroids or another inflammatory modifier like colchicine, and you are a fan of colchicine?
And I think this patient was too sick to waste time. So we felt that we needed really to hit him hard. So we gave him broad spectrum potent antibiotics, and at the same time we gave him high dose steroids. We wanted him to get better because he was not feeling well, and his family was too worried, and he had to be admitted like 1 or 2 times to the hospital with this.
We'll invite, thank you so much, Dr. Ramzi, for this very interesting case.